And if you are mobilizing somebody and they have had surgery, you have to be respectful of that. What I do is make sure as I have her arm, I cradle it or I have it in such a position that she feels safe. Okay? Oftentimes what I'll do is I'll just kind of talk to her and try to just see how she's feeling, and she gets used to me just holding her arm as I'm talking to her. And so I got her arm and I'm holding it. If you see how I have her, I got her from the front and I got her from the back. And I bring her over this way. Okay? And then if she has pain, I'll either choose to stop at that pain, or if I deem it appropriate, I can move past that pain. And do you feel kind of secure? Feel like I'm not going to like drop you? Okay? And then as we go into abduction, I'll hold her this way and bring her out this way. There may be reasons initially why you choose to maybe range somebody with the elbow flexed. Okay, they're just a little tighter, they're in a little pain, they're acute. I'm a little worried about how she's going to handle it. But again, remember, by doing that, am I going through her whole motion? I'm not, and I can run into restriction that way. So I might then want to range her with her elbow straight. Abduction here, okay, and then you come into the frontal plane 30 degrees-ish, okay, and then you do elevation. Okay, and that is called scaption. It is motion within the plane of the scapula. Those patients that are dislocators, okay, those patients that have had capsular shrinkages, patients who have rotator cuff tears, you're not going to force them back here initially, okay? So scaption's where you want to be, and you can work without really incriminating that anterior aspect of that capsule that much. But then what happens with internal rotation? The body gets in my way, right? Okay, I can put her here. Now if I put her here and work on her internal rotation, obviously external rotation and internal rotation, it's more provocative, okay, because I'm away from her thorax, but I'm able to get into those positions. I can range her like this, okay, I can range her in sitting, okay, and attempt to move her. I can put her over onto your belly, okay, if I'm going after the knee, I can range her here. Now tell me, what's the difference between what I did just before in supine? Hip flexor, okay, is out of the picture in supine. In prone, it's in, right? I have to have flexibility in that two-joint hip flexor in order to allow me to have knee flexion. Now, do you think it's important to range in both positions?
Yeah.
It is. You have to avoid the compensation, because I tell you, new grads do this all the time. You take range of motions, and she's like this because it hurts so bad, and you're trying to take range of motion, and you're like, oh yeah, it's looking good. And then when you put her down, she's lost about 10 degrees, okay, because she's compensated and you haven't corrected for her, okay? If I throw her on her stomach, I'm now bringing in that two-joint hip flexor and coming this way. And you need to take the measurements in both positions. Which position is better for her shoulder joint? Having her palm down like this, or having her over here like right. I want to put that shoulder in somewhat of a neutral or externally rotated position. Why? Okay, as that shoulder, as the humerus rides up, I don't want to pinch off those tendons that are coming up underneath the acromion. You're going to come out like this. This arm's going to do all the work, and you're going to bring it up and over your head as far as you can go into pain-free range, or however much you want her to go. And come back down. But by telling her not to use her uninvolved side, you're really going to limit how much she's doing here. The other thing you can do is do active assisted. You just change how you're phrasing it with her. So I'm going to say, Bethany, what I want you to do, she's going to do the exact same exercise, but I want you to do as much as you can with this arm, and then when you feel like you no longer have the strength, use this arm and help it along. Okay? Ready? Go. Go into abduction. Right? Real nice and simple. And back this way. Okay? Then, if we bend her elbows up, okay, could she not do external rotation? Okay? Could she not do, hold here, and bring them up and come over this way? Horizontal AB and adduction and come this way. Okay? So really simple type of exercise. They have wands that are weighted. So once you feel like she has good passive range of motion, you want to gain a little bit of strength going on in here. Supination, pronation, okay. You can, definitely do wrist motion as well.
So I could have them face this way, or I could have them face this way. Now, again, if you guys have a patient with a very stiff shoulder who's post-operative, which way do you think it might be safer for them or more comfortable for the patient to be facing? This way, exactly, because this is going to let them go into some degree of scaption, okay? Once you get them back here, and as Sue said, when you're doing true frontal plane abduction exercises, that puts a lot of stress on the anterior capsule, bicipital tendon gets tweaked. It's not that comfortable. It's not a bad thing to eventually work somebody into, but that is something that I would say I would avoid initially.
The issue is once I get past 90 or a little bit higher, if I'm in this position, I'm going to do what sometimes? I'm either going to hike my shoulder, I can hinge up, okay, on that humeral head. So oftentimes I don't use the ladder. I will have them walk up the wall until it gets about 90 and then turn their arms and then walk into the wall and come like that. You can do it this way too. Okay, yeah, I was going to show that too.
Just on the table, just have them put their arms down and then they just walk away. They're just walking out like this, and that's just another way of getting that passive range of motion. This position, this exercise is not tolerated well because think about, when you bring your shoulder back, in what direction does your humeral head move? Anteriorly, okay? So if you're getting a patient who has anterior impingement, and we'll talk about that, this is not a well-tolerated exercise. So how do you increase internal rotation without hurting their shoulder? You have them lie on their side with their shoulder at 90 degrees, and their elbow is bent at 90 degrees, and they just come down into internal rotation. And that's a really nice, comfortable stretch. It just stretches the posterior capsule. It'll help increase internal rotation, but it does not compromise the anterior shoulder in any way at all.
Yeah.
And then likewise, you can just, the arm across the shoulder stretch gets the posterior capsule.
She can use her other foot. So this is the involved side. I want to see her go up into extension, and she uses this leg to completely bring her up. Or we can do active assisted, and I could say, okay, Bethany, lift this leg up as high as you can. When you feel like you can't anymore, bring this leg up and bring it in, okay, and help move it all the way up. Then what we can do is the exact same thing for knee flexion. She brings it onto the other side, and she pushes her back. Okay, she's going to have some restriction here because of the table, though. So what position may I want to put her in?
Supine.
I can put her in supine or PROM. So let's go supine first, because you will be doing both. Okay? So anybody here of heel slides?
Yeah.
Right? So this was the leg we said, right? So she could do active assisted if we wanted to and say, okay, Bethany, what I want you to do is just slide your heel up towards your buttocks. Once you reach a point where she can't do it anymore, I use this leg and she continues to help push it. Okay? But we don't have what in here?
Rectus.
We don't have our hip flexor. So turn around, two joint hip flexor. All right, turn around. All right? And now what would we do? Okay, so now she comes up this way. Which one's going to be harder? This one. Muscular-wise. This one because of what?
Gravity.
Oh, you guys are brilliant. See, you're so much smarter than we were. I'd be like, I don't know. No, kidding. So she brings it up. It's hard for her here. She uses her other leg, pushes it towards her. Okay? Let's say she doesn't like this or whatever. Could I use a strap or a belt or a long towel? This one may not well here. When you've got long legs and long arms, it's a great exercise to do. Hip, same thing. I could put the towel underneath her and do hip range of motion that way. With our patients, they're in a flex position. Just having her leg here is a range of motion activity. But if I want to bring her through her motion, I'm going to say, Bethany, put your hands by your shoulders, okay? And you're just going to press up, keeping your pelvis on the ground. If you were to attach, and look at her muscular activity here, she's not getting anything. It's coming from her arms and from the position she is in and back down. Okay? I could just put her into prone on elbows if she couldn't get up all that way. And that's it's more of a stretch than a range of motion activity, but it's a good one. Okay, I could use a towel, or I could even use Bethany's hands. She reaches, grabs one leg, pulls it towards her. Right? These are William flexion exercises. Okay, we'll go over these with the spine. Okay, brings this leg up. Okay, keep your knees bent. I always keep them, and then come forward. Okay, and back. We can do, so that's kind of unilateral, and then she can bring both her knees up. Okay, and she could use a towel, a strap, what have you. And this is probably the easiest way. Right? And she can bend over, okay, and get her hands right in between her legs, okay, and spread your legs, and she can even hold on to the leg rest of the chair. Okay, she can do rotation. So instead of holding onto both, she can come up and over onto one side. Okay, and rotate or side bend over to that. Okay, so I bring her up to that first barrier, and if I'm purely just doing a manual stretch, I hold it here. Okay, and I hold it for 45 seconds or so. She might attempt to bend her knee. If you look at where my hand is, though, what am I doing? Automatically. Okay, I'm locking her out so that she can't fake me out. Okay, you don't do that, and you're not paying attention. You're like, whoo, yeah, look at that. So she's tight here. If I want to do autogenic, I ask her to contract her hamstrings. Now, Phyllis, listen to me. What I'm going to have you do, we're going to try to stretch out your hamstrings, okay? I want you, keeping your knee straight, to push down into my shoulder lightly, okay? Nothing more than 40%. So you can go lighter than that, okay? And we're going to hold, otherwise I'm going to hold. Be nice. And then you're going to hold that for about 20 seconds, okay? And then I'm going to ask you to relax, okay?
Okay.
All right. Ready?
Yep.
Push. Lightly. Good.
Yeah,
And
some
then-
people, their whole leg comes off, they're pushing so hard, their whole leg comes off.
Yeah. Or you're like, whoa, you don't need it. You just need a contraction. Relax. You let her completely relax, and then I go further. How you doing?